Welcome to another CME session from SJMC. We hope you enjoy the content.
And we are live. Welcome everyone to another SJMC Grand Rounds, and this is the 28th SJMC Cardiology Grand Rounds. I hope you enjoyed the sessions as much as we enjoyed providing them for you. I'm your host, Alan Tay. I've changed my appearance somewhat, became a little bit more digitalized. I'm just going to run through some housekeeping slides before I pass over to the chairperson for this meeting, Dr. Jayamala, accompanied by our colleagues, Dr. Choi Chan Ngok and Dr. Yap Lok Win. So today's topic is on simple ECG interpretation. So as usual, there will be case-based presentation followed by discussion. For discussion, we invite you to use Slido to ask questions. So you can join us at slido.com and you enter the meeting number 2543374. Okay, you can also scan this QR code to get into the meeting link directly. The session is you are eligible to claim one CPD point, which will be obtained by scanning the QR code displayed at the end of the talk. So you use the MMM app and then you scan the QR code, which is displayed, but it will only be at the end of the talk after the Q&A. If you are watching from a mobile phone, you can claim the points by taking a screenshot and save it to your gallery or album. And the MMA app can now scan from the screenshot. So you do not have to have two devices to claim CPD points. Okay, so without further ado, let me pass over to Dr. Jayamala to take over the session. Over to you.
Thank you very much, Alan. Thank you very much, and a very good afternoon to all of you. Today, actually, in September 2020, we first started our SJMC Cardiology Grand Rounds. And this month, September 2023, we would have been around for the last 3 years. This is our Grand Round number 28. We'll be having 6 short cases. In the first 3, we'll be showing you how important good history, ECG, and cardio biomarkers are in raising the suspicion that your patient's symptoms are due to coronary artery disease. And in the next 3 cases will be with simple arrhythmias. The first case is a 71-year-old man presented with a 6-day history of feeling unwell, a lot of nausea and vomiting. He denied chest pains or shortness of breath. Bowel habits were normal. He has a long history of gastritis, and of course, when he saw his GP made a diagnosis that was probably GERD, gave him gastric medicine. He did not feel any better, therefore came to ER. There's no past medical illness, and he's not on any medication, and he's non-smoker. In heart rate 70, regular. The blood pressure was a bit elevated at 116/90. The first test which the ERMO did was a TROP-T, point of care test. This is not high sensitivity test, and it was less than 40, which means that it was negative. So based on the clinical information so far, what are your thoughts, Priya?
Okay, so we have a 71-year-old with basically no risk factors, coronary artery disease, apart from his age, I would say, he's 71. He has not an uncommon presentation for nausea without chest pain. And of course, in this situation, without chest pain is obviously cardiac disease case straight from the start. Nevertheless, we be a little bit more careful. So my thoughts are that despite this being presented like the gastric case, I think we need to do a bit more investigation on the cardiac side. So maybe we will start with an ECG and some basic tests first.
This was the ECG that was done. Would you like to comment on the ECG, Dr.
Okay, so when I look at ECGs, I would say that I have a very quick glance, and sometimes when we have a quick glance, we will see the pattern straight away because we actually look at a lot of ECGs. So quick glance here, to me, looks like a normal sinus rhythm. But beyond that, I think we need to go a little bit systematically and just look at the rate, the rhythm, the P wave, the QRS, and the T wave. So going through that, the rate is about 70. The rhythm looks like a sinus rhythm. P wave looks normal. PR interval is normal. QRS and ST segment looks normal. T wave looks normal. So I think this looks like a normal ECG to me.
If I were to show you his previous ECG, okay, this was an ECG which was done previously. Is there any, would you now?
Yeah. Can we go back to previous ECG?
One which was done previously, this one.
Yeah. So again, this ECG also looks like a sinus rhythm with P waves, QRS that look normal. But it's always good to have the comparison. So if we put them side by side now, and we actually examine their ST segments in a little bit more detail, I would say that the latest ECG, the current one, maybe shows some very minimal ST elevation and some very tall T waves. So there may be some signs of hyperacute changes. Although it's very, very subtle, I can't be sure by just looking at the ECG on its own.
What do you do next?
So if we look at the overall presentation for this patient, we got a history which is fairly non-specific. We have ECGs, but ECG is not the only modality we have. So I would go on a little bit further to investigate this patient, maybe with an echo and maybe with a CT scan.
The echo was done. It doesn't show here. Well, I may have to use the other way of to show this CT echo. Basically, the echo showed a hypokinesia of the anterior wall.
Got the DC part on the
Yes. Just be with us for a little while because we try to use a different way. So, just
This is the part from this is the
this one.
no the video.
No, it's in the ECG. So maybe we go back to the usual way of us presenting.
Oh, yeah. And you have to I will share this instead.
There it is.
Sure. Yes, hang on for a minute. Share entire screen.
And sorry for the technology. We were trying a different approach, but
Then
then we will go on.
you can go to your presentation. Look on the PowerPoint. Very good.
Right.
Then present.
So So we echo. So what is echocardiogram? Comment upon the echocardiogram, Dr. Yap.
As you are playing it, the echo normally would show good motion all around on the left ventricle. So the video on the left side is a picture of the left ventricle and also of the mitral valve. And the one on the right side is also focused on the left ventricle. So as the ventricle is moving, we expect the movement in all walls, the left side, the right side, so the septal wall and the lateral wall, as well as the apex towards the top there to be moving well. And actually, in these two videos, we can see that there's a bit of limited movement or hypokinesia around the anterior and the apical segment of this echo. So now this patient has a negative troponin. So with the fact that there is some wall motion abnormality on the video, on the echo, then we need to come back and suspect that the patient may have underlying coronary artery disease.
Okay.
So that's even despite the negative troponin, an ECG with very, very subtle changes. And we actually see wall motion.
Biomarker not raised.
Hang on a second, Jemawa. There's a technical glitch. I don't know why you're not in the studio.
Okay. Why do you think the cardiac biomarker is not raised?
Hang on a second.
Well, it doesn't matter, he can answer it.
No, you can't see you.
Um,
Right now, you share, present entire screen. My screen. Sorry for the hiccup.
sometimes you do make sorry for the glitch. Why do you think the cardiac biomarker wasn't? Yeah.
Yeah, so we would expect the troponin should be raised when there is some form of myocardial damage. That means in terms of the coronary artery disease or the stenosis, it's going to be quite significant. There's going to be maybe like a 99% or 100% stenosis. But if you have a stenosis that's slightly less, then it's possible that during the investigation, like echo, you actually see that previous damage, but it's not acute. That means this time round, we don't actually have a very acute sort of fusion or 99% stenosis, but despite that, the patient might be having angina. So this is when the troponin is not raised, we say it's not non-STEMI. So when it's raised, it could be a non-STEMI. The patient may have unstable angina, hence the troponin is not raised.
So in other words, you're trying to say that this may be an old infarct, old occlusion,
Yes.
and just pick it up now that his symptoms may be actually gastric, but the changes you see is actually from an old event.
Yes. And this gastric symptom may be just gastric or also may be angina symptoms, but the troponin may not necessarily
It is also possible that maybe the troponins were done too early. that, it hasn't started to rise. That may be another reason.
That's a point.
Okay, so in that case, in that patient, what may have raised the suspicion was basically his ECG, which is slightly different from his previous ECG, whereas the history and the cardiac biomarkers, there was some doubts whether really symptoms were cardiac. Going on to the second case, this is another at 71. Again, I don't know, all my patients are 71 years old today. Again, a long history of gastric trouble. And she actually comes 5-day history of pain, mainly over the back and the left shoulder, associated with burping, no sweating, chest and epigastrium is not comfortable, but basically a lot of it is back and shoulder pain. Again, she saw GP, given gastric medicine, no better, so she came to ER. But she has severe risk factors, diabetes, hypertension, high cholesterol, quite well managed with the use of those medications. When she came in, the heart rate was 72, BP 130/80. Again, the TT point of care was raised at 68. This is not a high sensitivity TT, and the upper limit is 50. So TT was raised, but the history was atypical. So this is the ECG. Would you like to interpret it, Dr. Choi?
Thanks, Dr. Jia. So again, we have an elderly patient here who comes in with back pain. Before I talk about the ECG, of course, the common things that I'm sure the audience will be thinking of be like aortic dissection as well, which her BP is normal, which we don't really think of that. When we look at ECG, one glance, just like Dato Yap, I like to look things from far and looks like a very normal looking ECG. Sinus rhythm, not fast nor too slow. And of course, as we scrutinize into the waveforms, one look, it seemed to be normal to me. But if you can slowly zoom into maybe V2 and V3 with a bit of imagination, of course, one would probably say that the ST segment seemed to be a little bit too flat. When we see an ST segment that appear to be flat, it normally tells us that it's not entirely normal. And if you are a bit more imaginative, probably you will say that not only that it's flat, it's also a little bit depressed and downsloping. So to me, V2 and V3 is not entirely normal with a bit of subtle ST depression. And as we extend our vision over to lead 2, 3, and AVF with that degree of imagination, I would say that similarly, the ST segment is not entirely normal. I would always like to talk about reciprocal changes. When you have inferior leads that seem to be abnormal, then we start to wonder whether the lateral leads are also abnormal because they actually mirror each other most of the time. So when you look at the lateral leads, which is actually lead 1 and AVL, the opposite is actually seen. You can see that the SC segment can be, I think, arguably a little bit elevated in this ECG. So in conclusion, I feel that this patient has a significant degree of SC depression over the inferior and lateral and anterior leads with maybe a bit of ST elevation over the lateral leads. So in the presence of chest pain and cardiovascular risk factors, acute coronary syndrome should be the top of my list.
Yeah, I didn't have so much of imagination. I did think V2 was a little bit flat, but other than that, I really didn't think I didn't have as much imagination. But while I was being examined, she had severe back pain, and then we had to do an ECG. So what would you like to think about the ECG now?
So so as we look at the second ECG, seems like my imagination has gotten onto the right track. So the ST depression seemed to be a bit more depressed, 2, 3, and AVF, and similarly V2 and V3 as well. And now as we look at the AVL and lead 1, which are actually the mirroring leads, ST elevation is a bit more obvious. So at this point, I would say she could be having an acute STEMI involving the lateral segment of the heart based on this ECG.
Yes, so this lady went on to have an angiogram, and actually the costic vessel was a very small diagonal which was less than 1 millimeter, and the push was just left in the yes, but it was on the lateral wall side. So patient history mainly presented as back pain, very simple ECG changes, but the cardiac biomarker was raised. Okay, patient, I also didn't realize, another 71. Okay, so this man actually tells me he's a long history, epigastric chest discomfort whenever he goes for his walk. So this is normal for him. It occurs during the first 5 minutes, but as he continues to walk, it goes away and he can walk for an hour. No problem, doctor. If he has his breakfast before his morning walk, then it is worse. But otherwise, no problem. Nothing at rest. Otherwise, he says fit as a fiddle. Hypertension, hypercholesterolemia, again, quite well controlled, non-smoker. He was forced to come because the children said, you must go and check it out. Okay, so this is ECG. Okay, Dr. Yap, can you interpret his ECG?
Okay, so at a quick glance, I see that this is an ECG of the sinus rhythm. The rate is okay, 60. Now I need to have a little bit more close look at the P wave, the QRS complexes. And I see that there's in the QRS complex, there's a bit of M shape in the V1 and V2. So I think using the mnemonic which I use, Merrill, so the M in V1 and the W in V6 shows that this is a right. So the R in the Merrill shows that it's a right bundle management ECG.
So, that when you have a right bundle branch of the left bundle missed, artery is good. That's why he came to see me. Because he said, my artery must be. My abuse of this.
And from our experience, they are different. A right bundle branch block, which is the one that we've seen on this ECG, is a bit of a non-sinister finding in many cases. So young people in their 20s, 30s, they can have a right bundle branch block, and they may have a structurally normal heart and no evidence of coronary disease. However, there's a difference with left bundle branch block. You may see a left bundle branch block. Okay, so there will be a W in the V1 and M in the V6. This is a more sinister finding potentially, not always, but potentially more sinister. So if I see a left bundle branch block, what I would do is, first of all, try and look for an old ECG. Is this an old finding or a new finding? So if there's an old ECG that demonstrates that current left bundle branch block is a new finding, especially in the context of a case like this, where you have a patient with chest pain on insertion, then there's a high likelihood that this is a sign of coronary artery disease, causing some form of damage, particularly more commonly in LAD area. Or sometimes in the context of acute MI, they present as a left bundle branch block. Now, not always, because sometimes a left bundle branch block can be seen also in other conditions such as hypertension. So the clinical history is left bundle is more sinister and bundle less so.
He's told to have a right bundle. So he wasn't too worried about the right bundle. I knew I have it. But because the symptoms, I said, put on a stress test. Okay, so this was the initial. Dr. Yapna, can you please comment it? When he was doing his exercise, he started burping. And then this was his post exercise. Can you comment about the stress test, Dr. Yap?
Okay, so the initial ECG is a fairly normal ECG apart from the right branch block we've seen. And then during the exercise, there are not many changes. Comes tachycardic. There's no significant ST changes, but after exercise, you do see a change. And there's now, what jumps out at me is the ST depression in lead 2, lead 3, and lead AVF, but also in V2, V3, V4. So there's a fairly widespread ST depression. Now, in the context of right bundle branch block, we know that the stress test, when you interpret the ST segments, is not as accurate. So we have to take that right bundle with into consideration. And sometimes these ST segments may not necessarily indicate ischemia, although they do look like ischemia on the stress test. But I would also look at the patient's symptoms. So if he developed chest discomfort during the stress test, then maybe these are some significant changes on the stress test. And then the patient warrants further investigation.
Fine. Is it true that in right bundle branch you see speech changes? It's V1, V2, V3, which is in the area of block, then it may not be significant. But if you see it in like inferior needs like this, it tends to be usually more significant.
Yeah, so I agree with both of you all. I think in the bundle branch block, pre-existing bundle branch for ECG is a bit difficult to interpret, especially left bundle, because it's already ST segment abnormal being abnormal in the first place. For this particular ECG, of course, with the right bundle branch block, because of the very deep S wave in 2-3 and AVF, it can be very difficult to tell whether this is just the S wave or this is actually an ST segment depression. But for this particular case, I think it could, in the presence of symptoms as well, it could be genuine ST depression, because the ST segment that is depressed, right, cuts across the S wave pretty acutely, which tells us that maybe there are two different ECG abnormalities in this particular tracing. One is being right bundle branch block, and the other one is maybe a bit of a ST depression. And in fact, AVR itself, maybe there is a bit of ST elevation as well in this particular case, which brings us the fact that probably some kind of very small LAD disease is involved. But that also because of the symptom is quite typical in him. Otherwise, it's very hard to explain.
This patient had a high-grade LAD lesion. Again, this symptoms that he had, what they look like walk-through angina. So a lot of people think it's gastric, but actually it is classic walk-through angina, and he had the same symptoms stress test with associated ST segment changes, which therefore makes it significant. So the lessons to be learned are the threshold for doing an ECG should be low, especially in patients who are elderly or have severe responses. GERD is common, but if the patient does not respond to the usual gastric medicine, it may be something else. It may be cardiac, it may be something more malignant, but you have to just look for something else. An ECG done during the episode of pain is usually more diagnostic. And symptoms related to exercise, exertion, and relief with rest, even though they seem very atypical, should raise a suspicion that it is due to cardiac disease. Even if the pain is at the back or pain is in the jaws, but if it occurs on exertion and relief in rest, it may be. Cardiac biomarkers, that is, troponins, have a time lag, usually about 4 to 5 hours before they begin to arise, but they may be elevated in persons due to non-cardiac disease. Now, just in making a diagnosis of MI, one reading alone sometimes is not enough. If it is very high, then of course, coupled with the ECG and history, may be enough. But if history is atypical, ECG not very classical, according to the definition, you need at least a 20% rise from baseline to say it is an MI. And if the trop T is not very high to start off with, it may actually have to increase 50 to 60%. There should be a rise and or fall to make the diagnosis. Okay, and of course, there are many other causes for raised cardiac disease. Okay, now we move on to Dr. Yap's case, and Dr. Yap shall present.
Okay, so I have 3 cases to show. These are cases for patients that I've seen this year over the last few months. So the first case is a patient who came to the emergency. He's 52 years old and he came with a history of palpitations lasting for 1 hour with associated chest discomfort. Now, he has no significant medical history, but he mentioned that he has many times previously had palpitations, and every time he come, they couldn't manage to find anything abnormal on the ECG. So he does not know if there's any issue. He's not on any regular medication, and his BP is stable now, 140/80, but the heart rate is high, 160. So let's have a look at the ECG. And ask Dr. Jamala to interpret this ECG for us.
Thank you very much. Okay, as these down, first thing that strikes you is that the rate is very fast. You look at it, there are two small squares, so it's going at about 160. The second thing is, as you look at it, the QRS complexes are not wide, so it is less than 3 squares. You would say this is narrow QRS tachycardia. I think simple things that seems to be added. There are some ST segment depression seen in V5 to 6. This could be secondary to the tachycardia itself, causing stem-bound endocardial ischemia. So my diagnosis is a narrow QRS tachycardia.
Okay, so the diagnosis is SVT, which is what the ER referred me as. Now, Dr. Jaya, how would you manage the patient?
Okay, the first thing, of course, when the patient comes in with this sort of tachycardia, which is fast, is he hemodynamically stable? This patient's BP seems to be adequate. So that means I can take my time and try to convert him to sinus rhythm using some medications. If the BP was low, then of course I would have to. So to try to terminate this, the drug choice is IV adenosine, and it's important that it should be given with push. It should be pushed in and flushed with a lot of water. Sometimes when the first dose doesn't work, you may have to give a second dose, which is double that. First dose 6 mg, second dose 12. And if that doesn't work, sometimes I use IV therapy. So having terminated it, then of course the second point is you need to look at what is the predisposing factor. Why do you have some symptoms as it? Thirdly, long-term management is get more than one attack. So they all SBTs, and then we need to talk about drug therapy and something else, and how to manage it long term. This is how I manage this patient.
So we gave the patient adenosine. The first dose did not revert, but with the second dose of 12 milligrams, the patient then reverted to sinus rhythm. I will just mention briefly that how IV adenosine works. Basically, this drug actually slows AV node production, so there will be a transient bradycardia, and if it is an SVT, then very commonly it slows it down enough to break the circuit and restore sinus rhythm. So this is the post-adenosine ECG, which shows the patient's ECG actually looks fairly normal with the sinus rhythm. The next slide, please. So now, when we have a patient with SVT, if it's patient with otherwise very high risk, because we probably don't need to go on to check the coronary arteries, we would just do some basic investigation, such as echo, to make sure there's no structural abnormalities, and then also the blood test just to screen for thyroid function and electrolyte abnormalities. So in this patient, both of these tests were satisfactory. They didn't show any abnormality. And because this patient had multiple symptoms previously, we hence suspect that his previous palpitations were likely to be SVT episodes, and he should be referred for a permanent curative therapy, which will be SVT ablation. So now, since we referred this patient on, we would like to ask a very broad general question to the Choi. Should all patients with SVT be referred to ablation?
Generally speaking, of course, acute SVT is usually not associated with any kind of life-threatening risk. But I feel that this patient, the main difference is that when you look at this SVT, it is easily terminated by adenosine, which means that this is actually a nodal-dependent SVT. By definition, it could either be an AVRT or AVNRT. Now, these are all very highly curable conditions, meaning that with ablation, you actually can get rid of this SVT once and for all with a 99%, I think, cure rate, meaning that the patient will never get SVT ever again, 99%. So which means that physiologically and also socially, the patient could be spared from future events. I remember one patient that was referred to me is actually a chemo patient. So he has been having this palpitation and shortness of breath for quite some time. And when I saw this patient, his EF was very low. Very unusual, but sometimes we have these incessant SVTs, meaning that they have SVTs for days, in fact, to the extent that they develop cardiomyopathy. They have heart failure because of SVT. Not common, but that would be a very good reason to move ablation. So after ablation, the heart function went back to normal and no SVT episodes. Another patient to share is that the patient, just like this patient, paroxysmal SVT, sometimes comes to the hospital, get it treated, but one day ended up in Myanmar for vacation, and she developed SVT there, and it was very a bad event because communication breakdown and everything. And she came back, and the next day she came for operation. So socially and also physiologically, I think we have to take the cases individually. But in general, high risk and also refractory and incessant ones, ablation would be ideal for SVTs.
To affect quality of life, yes.
Yes, not just a one-time off.
So we'll move on to the next case. This is the second case. He's now a young patient, 37 years old, with chest pain and palpitations. And this time he's palpitations for about 2 hours. The GP did an ECG in the clinic, was concerned about MI on the ECG and referred to the SJMC. So this young patient has no significant history and is not on regular medication. BP is stable, 120, and the heart rate is 136 in the ER. So if we can show the ECG, what do you think, Dr. Choi, about the ECG?
Yeah, so at one glance, I'm sure we can all agree that this is tachycardia and it's narrow complex. Technically, it's a narrow complex tachycardia. Looking at the R to R beat variability is very variable, so it's irregular. Classically, we try to look for the P waves. And one may argue that if you look at some leads, for example, AVR or even V1, you could probably see some P waves over there. But I don't think they are consistent enough for us to say that these are P waves. So putting all in, atrial fibrillation should be equal to moderate. And I think this patient being young and having a tachycardia at this rate at rest, which is a bit unusual. So it should be an AF with rapid ventricular response until proven otherwise.
So yes, the diagnosis is atrial fibrillation. So in this case, the ER actually called me and said to me, you have a patient who was on call on this day with AF referred to there. So at this point, they asked me, do we need to admit this patient? So Dr. Choi, would you admit him and what would you do to manage?
Yeah, so this patient being, I would say, a young man who can give a very good history, sounds like this is an acute event. So acute onset and rapidly firing AF, feeling very uncomfortable. Was rate control and if possible, rhythm control would be ideal in him. And in order to do so, we probably have to administer anti-arrhythmic drugs. The first, coming to the hospital the first time, intravenous amiodarone will be preferred for this particular patient because we can monitor the adverse effects and also monitor the pressure. I would admit the patient and put him on, for example, amiodarone infusion, and hopefully to control the rate, and even better, to revert him back to sinus rhythm.
Okay. So that's what we did. We planned for admission, and although he's quite stable, because we want to give IV amiodarone, we have to admit him to CCU because it's hospital policy that if we want to give an intravenous amiodarone infusion, we have to admit for monitoring to critical care. So he was started on IV amiodarone infusion, and fairly shortly after, he actually reverted. So we can show the next ECG. which shows that he has now he's already in CCU. He has reverted to a sinus rhythm with a relatively normal looking ECG. So, further investigations for a young patient with acute atrial fibrillation. Now, the risk factors in general for atrial fibrillation is ischemic heart disease, abnormal thyroid, abnormal electrolytes, and abnormal heart structure. So we went through this. We checked his troponin, which was negative. His thyroid function is normal electrolytes. And at this point, we also want to know that he doesn't have a dilated or heart with abnormal valves. So we did an echo, which basically exclude that. His valves are normal, his LV function is normal. And the last thing that we went on to do is actually to check his coronaries. The CT showed that he has normal coronary arteries. So we move on now that he's in sinus rhythm to consider a very important question in AF. Does this patient need anticoagulation? So as you know, we have a CHEST-WES scoring system. So we go through the list. This patient does not have congestive heart failure, no hypertension, is not older than 65, no diabetes, no previous stroke, no sign of vascular disease like ischemic heart disease, and he is not female, he's male. So he doesn't score at all, and his CHEST-WES score is 0. Now, according to the guidelines, if your CHEST-WES score is 0, your risk for stroke is very low, and you do not need any anticoagulation. So I did not put him on any novel anticoagulation. He remained in sinus rhythm after a day or two of monitoring. I put him on a beta blocker to try and maintain sinus rhythm, and this chart came with follow-up in clinic. So that's the case. Now we have a third case. So this is another patient who came to the emergency. He's 57 years old. He had palpitations and chest discomfort for a week. And this patient also had previous several episodes of palpitation. Now he has diabetes and dyslipidemia, but mainly medication-wise, it's just on diabetic medications. BP is stable, 130/80, heart rate is 70. So we can show his ECG and ask Dr. Choi what do you think of this ECG.
Okay, so this is a very interesting ECG. So when you look at the first impression, it's bready. That's how I look at it. It's irregular. When you look at the R to R intervals, so we have an ECG with irregular heart rhythm and bradycardic. When you look at the P waves, one may agree that you can see P waves almost everywhere. In fact, we don't even know which is actually the P wave. Is it the one that's pointing upward, or is it the one that's pointing downward? Now, this is a very important concept because when you can't really decide where the P wave really is, the actual fact that it is actually no P wave, because the P wave is perpetually ongoing. This is what we call a sawtooth appearance, meaning that the P wave is not determined by a single focal point, but it's more because of electrical activity that goes around the heart. It's going around what we call as a macro re-entry. It goes round and round and round, and every round that it goes around the heart, it gives you a depolarization of both the atrial and gives you an ongoing depolarization of the P wave. So there's no real P, but it just keep on going on and on and on. And there's only one condition that can cause this kind of appear like this. It's actually a typical atrial flutter. And this atrial flutter is pretty well controlled because the ventricular rate is quite slow. So in summary, it's a typical atrial flutter ECG with a slow ventricular response.
Okay, so the diagnosis is atrial flutter. What would you do for management of this patient, doctor?
Yeah, so for any type of atrial fib or atrial flutter, I think the mainstay of treatment is rate control first, because when they have very fast rate, they may go into heart failure, especially it comes with heart cardiomyopathy or some kind of valvular defect. In this particular patient, the R to R interval is quite well spaced out. It's not really that tacky. Getting him admitted would be good for us to stratify the patient, like for example, echo, do some blood check and other evaluation. Sometimes one may even attempt to cardiovert the patient if the patient is actually covered in terms of anticoagulation. I would definitely admit the patient first and try out some antiarrhythmics plus minus of cardioversion.
Okay, so actually we did have one ECG, but in fact in the ER when he was monitored, he had quite a lot of variability in his heart rate. So occasionally he was going up to a slightly higher heart rate than what we saw in the ECG. So at this point, I wasn't sure whether he was going to remain in atrial flutter or revert. So as you mentioned, the thing that we would do is admit for monitoring and then consider anticoagulation later. But in the meantime, do some workup for risk stratification. So we put him on some bisoprolol and monitored him. But the next day, his repeat ECG actually showed that he had spontaneously cardioverted. So it wasn't intentional, so that we wanted to cardiovert him, like the AF patient previously, but he had actually reverted spontaneously. So that's good news for us. Now we know that he has paroxysmal atrial flutter. And so we start to do some further investigation for the patient. So we did an echo, and not uncommonly, when we see patients with atrial arrhythmias like atrial fibrillation or atrial flutter, we actually find that they've been in and out of these rhythms and they have a dilated atrium, or that actually, in fact, the dilated atria on both sides actually predispose them to these arrhythmias. Okay? So his LV function is normal. Now, because this patient presented with chest pain, I actually evaluated him for coronary disease. His CT shows that he has mild coronary artery disease, as you can see on the LED picture there. There's a bit of mild narrowing there. And so, coming back to using the same chest rest score, which we use for both fibrillation and flutter. Now, this patient is a diabetic. He will score 1. And also he has coronary artery disease. He will score 1 as well. So his score is 2. Now, the recommendation is if you score 2 and above, then you should be strongly considered recommended for oral anticoagulation. So we put him on Sevan. So we maintain medical therapy to try and maintain sinus rhythm by giving him a beta blocker and also anticoagulation with Ixaban, and considered for atrial flutter ablation later, because this is again a patient who has recurrent episodes of palpitations. So, Dr. Choi, in terms of beta blockers, we use this a lot in AF. How effective are they?
No, I guess to some extent, it is also considered some form of anti-arrhythmic agent. We compared to amiodarone and tobacco or other types of type 1 anti-arrhythmic. It's probably not as potent of them, but it is definitely a much safer drug to choose. Like for example, amiodarone it comes with multiple adverse effects, especially being used long term. Converting and maintaining sinus rhythm, it works occasionally by reducing the PACs. When you put the patient on the beta blocker, you can also suppress the PACs. So the PACs being suppressed, of course, that also leads to a lower recurrence rate any of these arrhythmia.
Dr. Choi, can I just ask you, you have been talking about supraventricular tachycardia, multifocal, atrial fibrillation. Physiologically, what's the difference between these arrhythmias that you're supraventricular arrhythmias that you've been talking about, and how does the management differ?
Okay. So, yeah, thanks. So I have a few slides to share. Strictly speaking, so we can divide atrial tachyarrhythmias into either SVTs or non-SVTs. So with SVT, it could either be AVNRT, AVRT, or atrial tachycardia, right? And if it's not SVT, it's either atrial flutter, atrial fibrillation, like what we've seen earlier, or the other type would be a multifocal ATAC. Now, how do we differentiate all these things? We're going to go to the next slide, the next slide as well. So SVT. So SVT is basically anything above the ventricle, either AVRT, or ATAC. Now, this is AVNRT. It's a bit busy to try to interpret the whole thing in the next 10 minutes. But let's just say that it is a reentrant. The concept behind reentrant is that you need two pathways. You need one pathway which is relatively slower than the other pathway. Because in order for a reentrant to perpetually continue, you need one pathway to go down and the other pathway to go up. And it has to keep on going on and on and on and on. And for this to occur, the refractory period of one pathway must be shorter than the other one. So that when the conduction activity goes down, the other pathway has already recovered, and it goes on and on and on. Now, this is the concept of reentrant. AVNRT simply means that the reentrant is occurring around the AV node. All right. So the difference is that the place of ablation is definitely somewhere around the AV node, which is very near the slow pathway. Whereas the next slide, AVRT, the same concept is also reentrant, but this reentrant is a bigger loop. It can either, for example, in this picture, going up via a pathway at the left lateral surface. But again, it is also a reentrant. That is why AVRT and AVNRT, when you give adenosine, 99% you will terminate the tachycardia. Like the example that we saw earlier, it's a very good case for ablation if it's functionally and physiologically affecting the patient, because you know that just by burning the pathway, you can actually get rid of the SVT. So this is AVRT. At the next slide, we'll show ATAC, atrial tachycardia. Atrial tachycardia usually focal, and you can see that the little picture on your right, you know, all these black spots, these are all the common places where you can get atrial tachycardia. And usually because it's focal, you can see that the tachycardia is a little bit irregular, but unlike atrial fibrillation, you can usually see the P waves quite well. And these three will actually make up the SVTs. Whereas the next slide, you can see atrial flutter and atrial fibrillation we have discussed earlier. So this picture, I got it from the internet, it's not mine. Clearly shows on the left, atrial flutter is a loop that goes around the tricuspid annulus. And every loop, if you imagine the heart, which is enlarged, everyone almost the same size. So one loop takes about 300 milliseconds, which means about 300 beats per minute. So we look at the P to P distance in atrial flutter is technically one small box. One small box is 300 beats per minute. The most common ventricular rate that you get, first time you see a patient is usually 2 to 1 block, which means that when they come to you, they get a ventricular rate of 150 beats per minute, which makes sense because 300 divided by 2 is 150. And this is the typical ECG of an atrial flutter. Whereas on the right, as you can see, atrial fibrillation, even to today, we have no idea the real mechanism and how the atrial fibrillation is technically being maintained. But we do know that most of this atrial fibrillation occurs from firing from the pulmonary veins. And when it gets fired, the AF just goes around in a very disarray and very disorganized kind of fashion. Hence, the AV conduction is very unpredictable. Then R to R intervals are always very irregular. So that's the difference between flutter and fibrillation. Now, for the last, before that, I purposely chose this ECG because one glance, it could be either AFib, which is technically you can't see the P wave, or flutter, where you can see perpetually ongoing P waves. But this is a very common mistake because this is actually not atrial flutter. This is actually atrial fib. Now, the reason why is because when you look at the flutter waves in one of the leads, like V1, for instance, you may think that this is technically a typical flutter going on. But if you can zoom in on your own, and you will find that the P to P distance is actually not the same. Remember, atrial flutter is a macro reentrant kind of tachycardia. It goes around the heart, and the heart won't change in terms of size unless you give them drugs. All right. So the conduction should be the same. These patients' P to P intervals are not the same. And if you look at other leads, you can see the P to P intervals start to change even more. So this patient is just having atrial fibrillation. But in this case, why would the P waves be so evidently seen? Because when you have atrial fib, sometimes certain leads may be able to see organized behavior, the depolarization, and that particular lead may be able to pick up so-called P wave. So not all P wave seen. This is technically an atrial fibrillation ECG. Just to share with you. And the last is actually multifocal atrial tachycardia. It's very hard to differentiate sometimes. One may think it's AFib, but if you look carefully, sometimes you can see P waves, and the P waves are technically changing. The reason why, because the firing is technically focal atrial tachycardia, but the firing is everywhere. Usually happens in COPD patients or patients with CO2 retention. But it doesn't matter because I think the management is probably almost the same. Rate control, and if you think the risk is high, sometimes you may even consider an anticoagulation.
Dr. Choi, just one or two other questions from you. Palpitations are common. For example, like a one-hour patients. If they're persistent, then you know they have time to go and have ECG done. But in many cases, it is paroxysmal, it is transient. And by the time they go to have the ECG, they don't have the arrhythmia. So what advice do you give your patient how they could document the nature of the arrhythmia?
Yeah, I think that's a very valid question. I would like to share my view first. This is probably one of the most common questions that patients come with nowadays. And I always empower the patient to be the physician. What do I mean by that? So when they come in with palpitation and they go to the clinic, the GP, most of the time you can't actually catch it. But nowadays with our wearable watches, for example, for instance, Apple Watch or Samsung or Huawei, and the list goes on, one may be able to do an ECG. So remember that, at the back of the watch is actually one lead. And when you touch the side of the watch with your finger, they will give you another lead. So it's a bipolar. So technically you have a lead one. You can have a lead one ECG by just touching the side of the watch, provided you get one of these watches. So when you have a palpitation or you have misbeats and you think that this is actually bothering you, you can actually instantly do that single lead ECG and store it into your phone. Next time you come to the clinic, and the patient can show it to the doctor, and we will be able to precisely correlate the patient's symptom to the patient's rhythm. Now, the danger of doing this is that sometimes you may pick up a lot of non-clinical rhythm, like a very short burst of atrial ectopics. And if you are overzealous in diagnosing this rhythm, one may overestimate the significance of it and end up giving them antiarrhythmics or anticoagulation necessarily. We will still say clinical symptom is important, and if we can catch some rhythm which is abnormal, and we put them on a home halter, for instance, and move on to that.
In AF and in atrial flutter, we did talk about anticoagulation. Now, should the anticoagulation be initiated before attempting to cardiovert the patient? The period. What are your views, Dr.
Widespread recommendation now is, yes, we also need to consider the risk because in AF, in the left atrial appendage, thrombus can form within 48 hours. So if you cardiovert a patient that already has thrombus, then the risk of stroke is very high. In those patients, we can actually consider to do PE, chances of to look for a thrombus before cardioverting to avoid a stroke. So the cutoff period is 48 hours. Within the 48 hours onset of EF, if we are very sure, then the recommendation is there's no need to anticoagulate with TE. 48 hours and above, there's a high risk of stroke. So these patients will need anticoagulation first for TE before we cardiovert.
Lessons to be learned in any patient complaining of palpitation and ECG diagnosis is important. And sometimes, as Dr. Choi says, a smartwatch may sometimes help to make diagnosis. In AF, most important is prevention or embolism because of the risk of stroke. And as Dr. Yap has pointed out, you use the chip that score. 0, you don't need anticoagulation. 2 and above, you definitely need anticoagulation. Treatment of the arrhythmia can either be by rate control using pharmacotherapy, beta blockers, etc., or rhythm control. Again, medications, cardioversion, as Dr. Choi pointed out, catheter. Thank you very much.
Okay, let me share. Thank you everyone for staying with us. And I was just checking the Slido for questions, and there's been no questions on Slido. Just a comment from somebody where the slides were a bit blurred. But sometimes I notice when the connection is slow at the beginning, it takes time to sharpen up. Anyway, I've tested, it looks just clear. No questions in the YouTube chat either. We've reached 1 hour, but as a non-cardiologist, I got a question.
Okay.
You know, those days when the patient come to ER with the SVT, we still used to do vagal stimulation, carotid sinus, press in the neck or eyeball. I'm reminded there's also somebody posted in the docs forum that there was a case of SVT, which was aborted by digital rectal examination. So even that can abort. So I think there's any role for these physical maneuvers still.
Yes, it's still the first thing that in fact, the ERMO has already done all those things before they call you and say that, ask you what to do. So yes, it is the first.
So there is still a role.
I mean, not the digital rectal, but
I think if you were to get SVT and then first thing you do a digital rectal examination, I think the patient would think you're a very strange doctor. It has been reported.
Maybe I can share a case with you. So some of my patients give me a very good way of terminating SVT is by sleeping. So by sleeping, you increase your vagal tone, and naturally, when they wake up, the SVT is gone, and they usually come to find us when finally even the sleep doesn't work anymore. So that's one way. I remember telling a patient to blow into a straw doing Valsalva and all. That's one tiny problem is that some of these patients, the more they do, the more anxious they get, and they can't terminate the SVT. Then the SVT go even faster because now that not only the vagal tone doesn't fail to turn in, the adrenaline drive goes up even higher.
Let me check again. Any questions? Okay, there's a question. For patients who reverted to sinus, I presume after atrial fib and flutter, do they still need anticoagulation if the CHAT score is more than 2?
So the recommendation for anticoagulation is regardless of whether you have permanent AF or whether it's paroxysmal. So we treat paroxysmal AF the same. We still use a chest rest score. And if their score is 2 and above, it is recommended that they have follow anticoagulation.
So AF, but revert to sinus, but if the CHAT score is more than 2, still anticoagulation.
right long. Even after ablation, recommendation is you need long-term anticoagulation. Although there are some studies which say that maybe you don't need so long, but right now the recommendation is
This is your chance to ask questions to our team of experts here. For any questions on SVT, AF, is verapamil still used? I remember it was an MO in those days. First drug we had was verapamil. We didn't have adenosine those days. Is it still used?
Yes, I use a lot of verapamil because patients don't like adenosine because when it terminates, sometimes you get a little pause and some of them feel like as if they're going to black out. So whereas with verapamil, when it converts, tends to be a bit more gentle. It's a second line. If adenosine fails, sometimes you use verapamil. But what I don't know about Choi. Yeah.
Yeah, we use oral verapamil also for rhythm control. Some patients with SVT, we sometimes give them oral work when they are discharged to try to control the SVT episodes.
Let's see. Oh, everybody understood everything perfectly. No more questions. So we will go on to the last bit. Hang on, what happened? Oops, sorry. Today a lot of glitches in sharing. Sorry, we will get that. Yeah. So get ready to claim your CPD point. So get your MMA app, and you can now scan this point. This code will be valid for about an hour, and after which it will expire. MMA has requested organizers to remind users, please do not share this QR code for people who did not watch the webinar. It's not very ethical, not to mention a bit of cheating. So please refrain. And we hope to see genuine participation, and we hope you enjoyed this session as much as I did, because for people not in cardiology, it's a fantastic reminder of the things which go on in the world of cardiology. And so many things now can be done for patients, including cure with heart ablation and so on. It's very good.
Thank
Okay.
you very much, everybody.
Yeah.
Thanks.
Yeah. Okay. Thanks. I will put up the code for a little while longer, and you can still claim your code. The video will be hosted still, so you can replay it, and then if you catch it within the next half an hour or so, I think the code is still valid. Yeah. That's smart. So okay, take care. Have a good weekend, everybody, and we'll see you in the next one. Okay.
Thanks, Alan.
Yeah.
Thanks.